Thank you very much for your introduction. Dear colleagues, dear friends, it's a real pleasure to be with you today and to participate to this annual conference. I will thank the organizing committee for inviting me to address this question of a Haplo donor versus unrelated donor transplant in high-risk AML. I have no real conflict of interest concerning my topic of today. And I do think that really to take the impact, to measure the impact of the questions that I will try to address today, we have to put that in the frame of the allogenic transplantation travel over the 60 or 70 years since the early beginning in the mid-50s. In fact, we have to realize that the first HLA match transplant for acute leukemia in humans has been reported in 1971 by Dean Buckner for the Seattle group. So it was 15 years after the early beginning of transplantation. And starting on this time, HLA matching for transplantation has become either a major limitation or a big issue. And the reason is because donor is really the cornerstone of transplantation. And as you know, very few patients finally have a matched sibling donor available for transplantation. In a country as my country, with a sibling as with the number of 2 or 3, the probability is under 25%. So it took some time, and in fact, it took 10 years after the first report of HLA match transplant to have the possibility to address this question of lack of donor. And in fact, 2 strategies was developed. The first one was to try to find HLA match unrelated transplant, and the second one is to find within the family mismatch related donor. So the first report on unrelated transplant for acute leukemia has been once again reported by the Seattle group by John Hansen. And at the conclusion of this case report, the authors stated that it was feasible rather than genotypically HLA identical sibling, but it was probably available for the patient who will have common haplotypes. On the other hand, the first report on mismatch transplant made by Ray Pauls in London show not so promising result. On a series of 37 patients, if I remember well, the rejection rate was around 29%, and the grade 3 to 4 acute GVHD was 80%, conducting to a high non-relapse mortality at 1 year of 54%. And because the best result was achieved in CR1 AML young patient, Ray Pauls at this time says that the probable benefit of this kind of approach could be only in young patients with CR1 AML. And you know the present reality showing that 40 years ago, it was very difficult to predict what could occur. Starting in 1980, so at this time, there have been many improvements in allogenic transplantation. But the real breakthrough concerning the topic of today occurred by the end of the 1990s with the possibility to do DNA-based HLA typing. And it is something indeed very important. In fact, if we look to one of the first report on a large series of patients receiving an unrelated donor transplantation, you can see that the main problem of this kind of approach is the occurrence of toxicity related to severe acute GVHD. Of course, this could be overcome by the use of T-cell depletion of the graft. But you know, as I know, that this kind of approach is associated with a loss in terms of disease control. So trying to get a really match donor to do the transplant was appealing, and the possibility to do this kind of high-resolution matching was of importance. And in this report from 2007, you can see that very clearly, whatever the disease, early disease, intermediate or advanced disease, it's better to have a good match to achieve good outcome rather than to have a partial match. So that was something very important, opening the gate to have less toxic transplantation. However, this kind of approach have a drawback because not all patients can find this kind of good match donor. And for example, if you look to the probability of such a success, classified in different from high to low, according to the frequency of HLA-DRB1 allele or the frequency and the frequency of DRB1, DQB1 haplotype, very frequent here, giving a high probability of finding a donor, going down to low or very low. The results are very interesting. In fact, for the majority of the patients, you are in this situation of high probability, and you will find a donor in 78% of the cases within 20 days in median, which is not so bad. However, if you are not in this situation of high probability, the figures are not exactly the same, as you can see here, going down to less than 20% for the patient with a low probability and with delay from 50 to nearly 500 days. And you have to keep in mind that this analysis was performed in German transplant centers. And it is important because most of the patients that have been included in this study were white Caucasian. And indeed, if you look to the probability to find a good donor in the US, for example, it's around 75%, the same numbers that what I have shown to you in the German study. But for other minority or other population, it is not the case at all, going down to 16% or less than 50%. So we have to keep that in mind. Not all the population can benefit from a match unrelated donor. On the top of that, there is something also which is important, is the fact that worldwide the odds are not the same. Here in this analysis of evolution of activity in terms of allogenic transplantation between the year 2000 2016 for related or unrelated donor transplant, you can see here that there have been an increase in terms of transplantation. But this increase was basically overall the same for related or unrelated. But when you look to the different parts of the world, it was not the same. You can see here, if you compare figures for European countries, that in fact there was a huge increase in terms of unrelated donor transplant. And it was the case also for North America or Southeast Asian region. But for Latin America or Eastern Mediterranean region of Africa, the increase was related to related donor transplant, but not at all for unrelated donor transplant. Meaning that probably the procurement of the unrelated graft is much more complicated in this country. And we have to keep that in mind when we want to evaluate the possibilities of treatment. So what about the evolution and the result of allogenic transplantation for unrelated donor? In fact, in this interesting report from Anon Nagler from the Acute Leukemia Working Party of the EBMT, you can see that on more than 3,000 patients who have been studied between the first decade and second decade of this century, there have been a nice evolution in terms of improvement for leukemia-free survival or overall survival. Of course, the numbers are low, but remember, all these patients have very high-risk disease, either primary refractory disease or relapse disease. So it means that really, and perhaps due to the fact that we can better match the donor and the recipient, the outcome has improved. Despite this improvement, there is still a medical need. Indeed, as I've shown to you, really, the transplantation cannot be performed in nearly a quarter of the white Caucasian, much more in the other population existing in different countries, and even less in patients living in countries as Africa or Latin America. So in this context, the possibility to do related haplo mismatch donor transplant is very important because, as you can see on this schema, you open the possibility to find different kind of donor. And in fact, it's only at the beginning of this century that the reality of T-replate allogenic haplotransplant become a reality, both in China and in the Occidental countries. In China, Professor Wang developed a strategy using high-dose pre-transplant EEG and high-dose myeloablative conditioning regimen, and with very interesting success. But I will not cover this aspect because I have no time to do that. But it's rather what we use in the other part of the world based on the use of cyclophosphamide after transplantation that I will focus my purpose. And this has been developed at the Johns Hopkins by Paul O'Donnell, Ephraim Fuchs, and Leo Lustig in Baltimore. And indeed, the post-transplant cyclophosphamide had a long story. I have been very fortunate some weeks ago to meet with Milivoje Boranik, which is now a young adult of 83 or 85. He's a Croatian doctor who, in fact, published in 1971 the use of cyclophosphamide in a mice model and shows that using this cyclophosphamide after transplantation could conduct to discriminate between the GVL effect and the GVHD reaction. So it was 50 years ago. A little bit later, in Japan, an author, Mayumi, showed that the use of cyclophosphamide post-transplantation was important to induce tolerance. But it's really after the work reported by Leo Lusnig that the possibility of using PTCY in clinic was important. And I have to insist, in this situation, it's high-dose PTCY, which is very different from many other experiments that have been performed before. I will not review in detail the mechanism, but you know that very well. In fact, when you give a dose or 2 doses of cyclophosphamide on day 3 and 4, you will eliminate the alloreactive T cells that have been proliferating after cell infusion, but you will spare the hematopoietic stem cell and the non-reactive T cells that at the end of the day will repopulate the patient. So many reports have been performed concerning haplotransplant, and in different disease, in different age, with different conditioning regimen, with different graft cells, but they all conclude to the same thing, that it's PTCY, high-dose PTCY in haplotransplant is very efficient to prevent severe and acute and chronic GVHD, and it is important, notably for older patients, this aspect of preventing chronic GVHD. And it's the reason why, in fact, the evolution due to the possibility of better unrelated transplant or more matched unrelated transplant and the possibility to do this mismatch transplant has conducted to a huge increase of allogenic transplant activity worldwide. In Europe, at the present time, 50% of the transplant are performed from an unrelated donor, 20% from an haplo mismatch donor, and it's basically the same numbers in North America. But in some centers, as in my center, the figures are not exactly the same. We transplant many more haplo patient with Haplo donor because we deal with an older population. In our center, the activity in terms of Haplo transplant reach 60%. So now if we go try to compare allogenic transplantation from an unrelated donor and Haplo donor, I do think that these meta-analyses on more than 20 different studies which have been selected, including more than 20,000 patients, is very informative. As you can see here, if you look for the non-relapsed mortality, clearly the patients who have received Haplo with PTCY are doing much better than the mismatch or the match unrelated donor transplant. For post-transplant relapse, it's not exactly the same. At least there is no difference for mismatch unrelated donor transplant. But in terms of unrelated transplant, it's basically in favor of unrelated donor transplant. In fact, you have to recognize, and I have to recognize, that it's retrospective studies with many differences in terms of population, many differences in terms of procedure of transplantation that could induce real biases. Is the reason why we decided in France to set up a prospective randomized study on the search, and I insist on this point, I will come back to that, on the search of an Haplo or unrelated donor to do allogenic transplant in patients older than 55. In fact, the trial was quite simple. At the time when we knew that there was no matched sibling donor, the patients were included in the study and randomized for an unrelated donor search or an Haplo donor search. If unrelated donor transplant was performed, the patient received this conditioning regimen with ATG as GVHD prophylaxis. If the Haplo transplant was performed, the patient receives this little bit different conditioning regimen and received PTCY as GVHD prophylaxis. We randomized 106 patients in 2 arms. And if you look to the population that have been included, you can see that the median age of this patient is 65. 80% of those patients have myeloid malignancies, and the DRI at randomization was 40% high or very high in both arms. And at the end of the day, in this intent to treat analysis, analyzing the outcome from the date of randomization, you can see that there is no difference in terms of progression-free survival. However, some details are of importance. As you can see here, if you look for an unrelated donor, you will find this unrelated donor only in 50% of the case. And it is the same figures for the search of an Haplo donor. So only half of the patient in both arms will receive only the targeted donor. Of course, we allowed for crossover, and you can see we can rescue around 20% of the patient. And the reason for crossover was not the same from a group to the other one. If we want to look for unrelated donors, the main reason not to do this kind of transplantation was the absence of this donor. When we wanted for an Haplo donor, the main reason to go to unrelated donor was the fact that the donor we tried to find was contraindicated. And remember that in the Haplo situation, the donors are not pre-screened, which is a difference with the registries. But at the end of the day, you can see that in both arms, a quarter of the patient did not receive the transplantation. And the main reason for that was relapse or progression prior to do the transplantation. And this is an important message, because you can imagine that it is an urgent indication to do the transplantation, but any delay going to this transplantation will increase the proportion of patients relapsing. Now, if we look to the patients who have been really transplanted according to the transplant they received, and looking to the outcome from the time of transplantation, So we can compare 77 patients. We have basically the same characteristics than in the intent to treat analysis, except for something. Time to randomization, from randomization to transplantation was much longer, 20 days, in the mud transplantation as compared to the donor, Haplo donor transplantation. And on the top of that, you can consider also that if we need a crossover and you compare the patient transplanted with the first donor and the one who needed to have a second cell, you extend the delay to transplantation of nearly 40 days. So these two parameters, time to transplantation, analyzing the time to transplantation, are very relevant when I come back to the figures of 16% of the patient who didn't get any transplantation because of relapse. Now, at the end of the day, as you can see here, no difference in terms of outcome, whatever the outcome you look for the patient who have received Haplo or donor transplant. So now, when you address this question of Haplo versus unrelated donor transplant, HLA perhaps doesn't seem to be the best criteria. Other parameters are important. I have no time to review everything, and I will focus on 2 or 3 slides on the age of the donor and also on GVHD prophylaxis that I think are very relevant for the topic of today. In fact, age is something important. Many years ago already, it has been reported that an younger donor will conduct to better outcome in the situation of unrelated donor transplant. And it is the case also in Haplo transplant. In a recent study we performed with Dr. Mariotti in Milano, combining the data from Marseille and different Italian centers, we have been able to show that the non-relapse mortality was increased with an older age, as well as the progression-free survival was decreased with an older age. And on the top of that, the relationship between donor and patient is also of very high in patients with worse outcome for when the donor is a parent. Now, if we look if you try to answer to the question, is it better to have a young mismatch Haplo donor or an older fully matched unrelated donor? I do think this study tried to answer this question. What I can say at least is that there is no disfavor to use a young Haplo donor as compared to older adult unrelated donor, as you can see here, whatever the outcome you look at. So GVHD prophylaxis is something important. In all the studies I have shown to you, PTCY have been used for Haplo, and it become to be more interesting in match-related or donor. And in fact, the question is, will PTCY change the pattern of allogenic transplantation in the HLA match transplant? In fact, Eolia Brissot from the Saint Antoine Hospital set up this prospective trial in France, where patients with an HLA match were randomized to receive either cyclophosphamide or ATG. And as you can see here, at the end of the day, for GRFS, which was the primary question, there is really no difference. So I'm not sure that PTCY will change anything. Cost effectiveness and cost is also something that could be of relevance for the patient in some part of the world. You can see that transplantation from an Haplo donor is cheaper than from an unrelated transplant. For half of the reason is the graft procurement, but in terms of cost effectiveness, Haplo is also much more cost effective than unrelated transplant because the results are not so different. So in conclusion, I will try to give you at least my truth, and I will say that MUD and Haplo donor will give the same outcome. Largest prospective studies are in favor of that. We have performed this prospective study in older patients. The problem is that real world interfere with the a priori medical choice of the donor. First, only half of the patient receives the desired treatment. A quarter of them will not proceed to allotransplantation because mostly of relapse. So the delay to transplant have to be taken into account, and it's sure that Haplo donor identification is more rapid. And if you don't look for any donor at the beginning of the story, you will lose more days for some patients. Haplo donor has enlarged the possibility of transplantation. Most patients have a donor, but many patients, and I do think that's very important, have several donors, allowing for a fine-tuning of donor choice on different other parameters, and notably the time to identify the donor. So it's really the door open for a personalized medicine in our practice. So I will thank all the people working with me in Marseille, in our department, and notably Régnier de Villiers performed some of the analysis I have shown to. And now I would be ready to answer any question if you are. Thank you.